Clinical trial design assumes independence between patient arms as a source of safety. Independence of outcomes is treated as sufficient protection against systemic risk. This assumption shapes how trials are powered and how adverse events are interpreted. Independence is one property of the joint outcome distribution. Absorption by a clinical threshold is another. Patient outcome independence measures the tendency of outcomes to co-move. It describes probabilistic separation between individual trajectories. It does not measure the proximity of any individual patient to a clinical deterioration threshold. Independence and absorption are structurally different objects. Independent patients can each independently reach a clinical deterioration threshold. Each patient follows their own physiological path toward the same absorbing boundary. No correlation between patients is required for deterioration to occur. Independence does not remove the existence of clinical absorbing states. Each patient's deterioration is a pathwise event. One patient crossing the clinical threshold does not require other patients to fail simultaneously. Absorption occurs along a single patient trajectory. Correlation across patients is irrelevant to whether any individual patient is absorbed. Independent patients each face absorbing states, death, permanent disability, with their own probability. The joint probability of all patients failing simultaneously is not required. Each independent patient faces their own absorbing clinical boundary. Independence distributes the timing of adverse events. It does not prevent them. Uncorrelated clinical outcomes still each carry independent absorbing state risk. Reducing outcome correlation does not reduce each patient's individual risk of crossing a clinical threshold. Clinical safety is not independence of outcomes. Safety requires that absorbing clinical states be structurally unreachable for each patient. Independence-based trial design cannot provide that guarantee.